Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article Risk of Diabetes Mellitus in Long-Term Survivors of Hodgkin Lymphoma by Frederica A. Van Nimbian et al. My name is Andrea Ng, and I'm a radiation oncologist at the Brigham and Women's Hospital and Dana-Farber Cancer Institute in Boston, United States. My oncologic specialty is hematologic malignancy with focus on cancer survivorship. This study evaluated the risk of diabetes mellitus in 2,254 long-term Hodgkin's lymphoma survivors treated between 1965 and 1995 and analyzed the effect of radiotherapy on diabetes risk. The presence or absence of diabetes was ascertained through medical chart review and physician communications. Treatment data, including radiation field and dose, were obtained from medical records, and radiation dosage to the pancreas and subsites of the pancreas were estimated from a model developed based on radiation dosimetry data on a selected group of 71 patients from a previous study. After a median observation period of 21.5 years, the 20 and 30-year cumulative incidence of diabetes were 4.1% and 8.3% respectively. With adjustment for radiation dose, there was a significant 1.44-fold risk of diabetes with a larger field that included the spleen compared to a periodic-only field. After adjusting for radiation field extent, a prescribed dose of 36 gray or higher was associated with a significantly greater diabetes risk compared to doses of less than 36 gray with a hazard ratio of 2.04. Importantly, there was a significant correlation between diabetes risk and estimated mean dose to the pancreatic tail, where the islets of Langerhans cells are concentrated. Compared to a mean pancreatic tail dose of 0, a mean pancreatic tail dose of 36 gray or higher was associated with a significantly elevated 2.43-fold of diabetes, while the risk was not significantly elevated at lower mean doses. This latter finding is especially relevant to modern radiotherapy planning for lymphoma as we move away from field-based to volume-based treatment. Although the reconstructed doses to subsites of the pancreas were largely estimates, the approximated dosimetric data in fact strengthened the finding of a significant radiation dose-response relationship, since the uncertainties would have diluted a true significant relationship. The association between abdominal irradiation and risk of diabetes has also been shown in testicular cancer survivors and childhood cancer survivors. In a Norwegian study on cardiovascular risk factors and morbidity of long-term testicular survivors, at a median follow-up of 19 years, diabetes was found in 7.3% of the survivors, comparable to the incidence reported in the current study. Patients who received radiotherapy, most of whom were treated with periodics and pelvic radiotherapy, had a significantly increased risk of developing diabetes. Compared with patients treated with surgery alone, the odds ratio of diabetes in the radiotherapy cohort and the chemoradiotherapy cohort were 2.3 and 3.9 respectively. As pointed out by the authors, 2 prior studies on childhood cancer survivors have also shown an association between abdominal radiotherapy and an increased risk of diabetes. In the childhood cancer survivor study, among the 8,599 surveyed survivors, 2.5% reported taking a medication for diabetes. On multivariable analysis, the odds ratios of self-reported diabetes were 2.7 and 7.2 respectively in patients with history of abdominal irradiation or total body irradiation. In childhood cancer survivors, the association between total body irradiation and diabetes risk may also be mediated through insulin resistance from growth hormone deficiency, in addition to direct effect of the radiation on insulin-producing cells in the pancreas. In the French-British questionnaire study on 2,520 childhood cancer survivors, 2.5% had reported and confirmed diabetes. Similar to the current study, doses to endotopic sites were estimated from reconstructed radiotherapy plans on the Phantom, and a significant correlation between the mean pancreatic tail dose and diabetes risk was similarly identified. However, in contrast to the current study, a significantly elevated risk was detected at a mean pancreatic tail dose as low as under 10 gray. This discrepant findings could be due to differences in the way that diabetes was ascertained and varying underlying contributing patient and treatment factors related to the primary cancer diagnosis. However, the difference in age at treatment exposure is likely a key explanation for the different findings. Indeed, in both studies, younger age at radiation exposure was significantly associated with a higher risk of developing diabetes, suggesting that in younger patients, the pancreas may be more sensitive to the effects of radiotherapy. The findings of this study have important implications for the follow-up of historically treated long-term lymphoma survivors. An increased risk of cardiac morbidity and mortality in long-term Hodgkin lymphoma survivors is well documented. In addition, there is extensive literature demonstrating the significant effects of traditional cardiac risk factors, including hypertension, hyperlipidemia, diabetes, and tobacco use on the cardiac risk. The contribution of diabetes to cardiac risk in cancer survivors is not limited to irradiated patients, but has also been demonstrated in other cancer survivor groups treated with anthracycline. In a SEER Medicare analysis of anthracycline-associated cardiotoxicity in breast cancer patients, the hazard ratio of congestive heart failure was significantly elevated at 1.74 in women with pre-existing diabetes. In another SEER Medicare analysis of non-Hodgkin's lymphoma patients, the hazard ratio of anthracycline-associated congestive heart failure in patients with pre-existing diabetes was significantly elevated at 1.27. The results of the current study highlight the importance of screening for diabetes, especially among long-term lymphoma survivors who have received historical large-field and high-dose radiotherapy and who may also be at increased risk for cardiac risk as a result of direct effects on the heart of other cytotoxic therapy, such as mediastinal irradiation or anthracycline therapy. Although the findings of this study may not be applicable to the majority of Hodgkin lymphoma patients diagnosed and treated in the contemporary era, as periodic irradiation is no longer routinely used and doses beyond 30 gray are rarely needed for Hodgkin lymphoma, there will be a small subset of patients who may require radiation therapy to the upper abdominal region. For patients with disease in the lower mediastinum or upper abdomen, where involved site radiotherapy may result in doses to the pancreas, the dosimetric data of this study provides valuable information in guiding radiotherapy planning. The results suggest that in applicable cases, the pancreas should routinely be included as an organ at risk in patients treated with curative intent, with a target mean pancreatic tail dose of 36 gray or perhaps lower, especially in younger patients. With modern conformal techniques and contemporary radiation volume and doses for lymphoma, this target metric should be easily achievable in the majority of cases. The authors of this study are to be congratulated for their important contribution to the Hodgkin lymphoma survivorship literature. The results not only provide evidence for optimal follow-up in historically treated long-term survivors, but also offer important dosimetric data guiding radiation treatment planning for selected patients with upper abdominal disease involvement. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.